Dear student, this is the second part of our lecture. Deep bite. Deep bite is one of the most common malocclusion seen in children as well as adults, and is most difficult to treat successfully. Unfavorable sequelae of this malocclusion predispose a patient to a periodontal involvement. Functional problems and temporomandibular joint disturbance. Deep bite anteriorly could be caused by supra-eruption of upper and or lower incisors or infra-eruption of posterior teeth. Methods of deep bite correction are extrusion of posterior teeth, intrusion of anterior teeth, combination of both proclination of incisors and orthognathic surgical modality. According to Bishara, deep bite as defined as malocclusion in which the mandibular incisor crowns are excessively overlapped vertically by maxillary incisors when the teeth are in centric occlusion. Unfavorable sequelae of this malocclusion predisposes a patient to periodontal involvement, abnormal function. Bruxism could be the clinching of temporomandibular joint, and if you classified the deep bite, we can divide it as an open bite to dentoalveolar deep bite and skeletal deep bite, true deep bite and pseudo deep bite, or incomplete deep bite and complete deep bite. Incomplete deep bite occurs when incisor relationship in which the lower incisor fails to occlude with either the upper incisors or the mucosa of the palate when teeth are occluded. Complete deep bite occurs when incisor relationship in which lower incisor contacts the palatal surface of the upper incisors or the palatal tissue when the teeth are in centric occlusion. The deep overbite may be caused by inherited or acquired factor. Inherent factors like tooth morphology, skeletal pattern and malocclusion, condylar growth pattern. Acquired factors like muscular habits and changes in tooth eruption. A deep bite anteriorly could be caused by supereruption of upper or lower incisor or infra-eruption of posterior teeth. To evaluate whether infra-eruption or supra-eruption is present, the orthodontist must use linear measurements from the base of the alveolar processes. These can be established by cephalometric analysis. For stability in function and retention, it is vital that the deep bite-incisor relationship be corrected to establish the proper interincisal relationship of overbite to overjet and interincisal angles. Treatment modalities of deep bite include extrusion of posterior teeth, intrusion of anterior teeth, combination of both, proclination of incisors, and surgical treatment. The modality of correction of deep bite is most commonly indicated in horizontal growing patient. It is very important to consider the horizontal growing of mandible. The removable bite planes, myofunctional appliances such as activator, bionato, functional regulator, twin blocks allow the extrusion of posterior teeth, thus opening the bite. Also, we can use cervical headgears, exert a vertically downward component of force of about 200-300 grams per side for duration of 14-16 hours per day. This creates potential for extrusion of the molars and the deep bite get corrected. Fixed sorry for that. Fixed modified NANS appliances or fixed bite plate with glass ionomer cement and bonded bite planes with composite resin on the palatal aspects of maxillary incisors also can be used for extrusion of posterior teeth. If you look at this slide, you can see fixed bite plane cemented with bands on the first maxillary molars. In occlusion, the mandibular incisors are in contact with the bite plane, and between the maxillary and mandibular premolars and molars, we can see separation space of 3-4 millimeters is created. This one is created for vertical development of the buccal lateral segments, like highlighted with yellow arrows, and thereby in frontal area we will get opening of bite. Treatment is also treatment for deep bite always require the leveling of curve of the spee. There are essentially four ways to reduce a deep overbite associated with an increased curve of spee in the lower arch using conventional orthodontic mechanics: buccal segment extrusion, relative incisor intrusion in a growing patient, incisor intrusion, or incisor proclination. Buccal segment extrusion of the lower buccal segments whilst maintaining lower incisor eruptive position is a very effective way of reducing an increased overbite. This is particularly true in a growing patient, where these tooth movements will produce relative incisor intrusion because vertical growth at the condyle helps compensate for any increase in the vertical dimension induced by the molar extrusion. In adult, there is little or no growth potential at the condyle, and buccal segment extrusion will simply result in a downward and backward rotation of the mandible, steeping of the occlusal plane, and an increase in the lower face height. This will reduce the overbite, but tends to worsen any underlying skeletal class 2 relationship and is prone to relapse following treatment. For these reasons, overbite reduction can be more difficult in adult patients. Buccal segment extrusion can be achieved using a removable appliance with a flat anterior bite plane, as you highlighted before. The appliance opens up the bite and allows eruption of the buccal segments, leveling the curve of Spee and reducing the overbite. And as you see, many functional appliances have a similar bite plane effect if the acrylic of the appliance here is removed over the lower premolars and molars to allow eruption of these teeth. Using an edgewise fixed appliance with a continuous arch wire can also achieve buccal intrusion. These changes can be accentuated by using a rectangular stainless steel arch wire with a reverse curve of Spee. The lower second molars are generally included to increase vertical anchorage and aid this movement. Care must be taken, as there will also be a tendency for the lower incisors to procline, which will assist bite opening, but may not desirable or stable, as you see in these cephalograms. Therefore, it is often necessary to place lingual crown torque in the label section of the arch wire to counter this. This judicial use of class 2 intermaxillary elastics will also assist in overbite reduction, as the vertical component of force will tend to extrude the mandibular molars. Class 2 intermaxillary elastics are integral in typical edgewise appliances, which aim to reduce and increase overbite early on in treatment by the use of rigid round steel arches that bypass the premolar teeth to create a long range of action and light forces. An intrusive force is applied to the label segments from the arch wire by tip back or anchor bands placed into the molar tubes, and an extrusive force applied to the molars by the use of light class 2 elastic. Together, this is very effective at reducing and increase overbite. True intrusion of the incisors in cases with a high maxillary mandibular planes angle and a class 2 malocclusion molar extrusion can result in an undesirable downward and backward rotation of the mandible, especially in non-growing patients. A deep overbite in these cases, also not common, should be in one segment extrusion. Also, this will also be accompanied by some incisor reduced by intrusion of the incisor teeth. Absolute intrusion of the incisors is mechanically difficult to achieve and requires fixed appliance always. The general principle is to establish an anchorage unit in the buccal segments and intrude the incisors with a utility or bypass arch pitch against the buccal teeth. More recently, the use of microimplants has been described to intrude anterior teeth, whilst intrusion can also be achieved using segmental surgery. Proclination of the incisor. A deep overbite can also be reduced by incisor proclination and an associated reduction in the interincisal angle. As a general rule, lower incisor proclination is unstable, as we said before, and there will be tendency for these teeth to return to their pre-treatment position, with a potential return of the increased overbite. However, where the lower labial segment is markedly retroinclined, such as class 2 division to malocclusion, some proclination of the lower incisors may be necessary to establish a class 1 incisor relationship with an acceptable interincisal angle. This can effectively be achieved with fixed appliances, especially in the presence of crowding. By engaging the initial aligning arch wire fully, the teeth will align by proclination, and this can be supplemented further by placing a rectangular stainless steel wire in the lower arch once the teeth are aligned with a reverse curve of spin. Any significant proclination will invariably require long-term or permanent retention following appliance removable to prevent relapse of the overbite. So, to intrude the upper incisors, the best placement of mini-screw is between the upper lateral incisor and the canines. The placements of the mini-screw should be done after leveling and alignment of arch wire in order to maximize the interradicular space at the placement site. In order to avoid tipping the upper incisors buccally during the intrusion, the end of the arch wire is clinched back. Some orthodontists use magnets or aluminium nickel cobalt magnets, samarium cobalt magnets or aluminium nickel cobalt magnets. They use on buccal or in lingual or palatal side, but commonly used on buccal side in attractive mode. The force generated may average 120 grams, which may be controlled by operator by adjustment of the air gaps. Less air gaps between the magnets generate more force. So for intrusion of a tooth, along with incisal positioning of the edgewise braces, sometimes they place more incisals, a bend is given in an archwire in such a way that the anterior segment of archwire is made to lie gingivally to the braces groove, like here. They make more gingival to the braces groove. Use of continuous archwire for opening the bite has found to have deleterious effects on the anchorage units. Extra care is needed to prevent these side effects. In an adult who has more than 6 millimeters of overbite, or 8 millimeters of overjet could be considered a candidate for surgery solely on the basis of dental relationship, without even considering facial aesthetics. The surgical treatment options in deep bite patients are orthodontics and interpositional genioplasty, orthodontics and inferior onlay mandibuloplasty, orthodontics and mandibular advancement, orthodontics and total subcubical mandibular advancement, orthodontics and inferior repositioning of maxilla and mandibular advancement, orthodontics and combined maxillary and mandibular surgery. Sometimes we have a problem with root resorption from apical root resorption after intrusion, and it depends to a large extent on the anatomical environment of the tooth. In young patients, apex is often surrounded by spongy bone and long marrow spaces. A light continuous force, such as that obtained in the light wire technique, has proven to be favorable for intrusion of teeth in young patients. If the bone of the apical region is fairly compact, as it is in some adults, a light interrupted force may be preferable. If a definitely light force is exerted for a period of 5 to 6 weeks, there is less tendency to root resorption during the later period of intrusion. In summary, we can say that deep bite is a malocclusion that occurs in vertical plane of space. Some degree of vertical overlapping or overbite is a normal feature of human dentition. However, some patients present with excessive overbite termed as deep bite or deep overbite. The deep bite in the permanent dentition may be caused by inherent factors or factors acquired during the life of that dentition. A successful treatment of deep bite requires a careful analysis of the factors contributing to the problems. During the treatment planning, Consideration should be given to the soft tissue, skeletal pattern, stability, occlusal plane, interocclusal space, treatment time, and age of the patient. It is widely accepted that correction of deep bite is both easier to accomplish and more stable when it is performed on growing patients than when it is attempted on those with no appreciable growth remaining. Adults often need only correction of excessive overbite, either due to its isolated nature or a demand for limited treatment. In adults, this treatment is often part of periodontal, restorative, and temporomandibular joint therapy. Deep overbite can be corrected by many ways, like intrusion of anteriors, extrusion of posteriors, combination of anterior intrusion and posterior extrusion, proclinating anteriors, or surgically. However, it should be decided which methods will be more beneficial or which will improve the patient's facial appearance and functional efficiency. And thank you for today. I hope to see you next time.